All right, so we are back and we are looking at our clinical solutions related to tongue thrust. I think by now you know that I'm not one to sit by and complain about the dilemmas. We're going to get on to making some solutions. So we'll look at what do we do about the tongue thrust now that we understand what it is and maybe why it is. When is it appropriate to intervene? And of course there's no simple answer here. It really does depend. And the reason I say it depends is because it depends on some of those factors we just talked about. If they have oral habits or contributing factors that can be addressed early on, then why wait? You know, get rid of the thumb, get rid of the necklace or the blanket or the binky or whatever it is that's in the mouth. Those habits can be eliminated much easier when someone is young rather than older. So by all means, that would be an intervention, and that would be appropriate as soon as it's identified, basically. Same with the tonsils and adenoids or sinus issues. Those things can be addressed whenever it is medically appropriate. You don't have to wait for a magic age when it comes to some of those contributing factors. Articulation is another place that can be addressed developmentally as appropriate. Speech language pathologists, when we're trained, we learn the developmental norms for sounds when they naturally come in, and there's an age range there. And so if it is within that child's age range, for example, R is a late developing sound. You know, if a child is 3, we're not going to remediate the R, but we may work on the S. So it would just be dependent upon, you can work on placement and, again, some of those contributing factors, but you're not going to address the swallow until the child's old enough to understand and change the behavior with education. The magic number that I use and that comes out of the literature and research is historically 8. And again, if you just think about a child's development, 8 is when they're able to pretty much sit down and buy in and be a player in what's happening in their body. And before that, it's really happening to them, not with them. And the swallow therapy is changing an automatic behavior. And so they really need to understand that and be able to participate in the voluntary exercises and activities that can then lead us to changing that automatic behavior. So you can treat earlier than 8, and like I mentioned earlier, I have had situations where it has been appropriate to intervene before they're of that ideal age, but they're just not going to make as fast of progress because just aren't as vested with it. So you're not going to have the 10 visits and the no 2, maybe, and maybe 15 visits, and they're going to need a lot more oversight from their parents, making sure that they're doing their exercises and that they're doing them properly. So that's the answer on it depends. So what does it look like? You can expect when you come in to see a speech language pathologist who's trained in tongue thrust, at least with a STTP, you are going to see this consistency throughout that process. So the first thing that's going to happen is we're going to complete a thorough history and informational interview. It's important to know what those contributing factors are. It's important to know what's going on in developmental history. We also need to know, we also need to complete an oral motor examination. The oral motor exam is a hands-on examination of the mouth, basically. We're looking at all of the face, the lips, the teeth, the tongue, all of those things. And then the clinical swallow evaluation, which is an extension of the oral motor examination and is unique to the STTP. Any good therapist, in my opinion, is going to do a complete and thorough history and oral motor exam. But very few tongue thrust therapists will do a clinical swallow evaluation. And in my opinion, it is a critical piece. So what do these things look like? Again, I don't share this information so that you can go out and do tongue thrust therapy, but so that you can know what to expect and to know, again, competencies, what it is you're looking for in a practitioner, okay? The history and interview is composed of a thorough developmental and family history. The informational interview will discuss known contributing factors that we talked about earlier. And this little caveat I think can't be understated, and that is that don't assume that because the patient doesn't demonstrate any developmental delays or disorders or contributing factors, that they don't demonstrate a tongue thrust. You cannot diagnose or rule out tongue thrust strictly on a history and interview. I have sat across the table from many a patient and parents who don't have any significant report of any developmental delays, any disorders, any contributing factors, and when we get to the swallow eval, they have got an incredible reverse swallow. So you are doing a disservice to your patients if you are a therapist and you discard that. And as a consumer, I would say if they're not thorough enough to include the clinical swallow eval, it's incomplete. The oral motor examination, what you're looking for here is that traditionally they're done prior to the clinical swallow eval because a couple reasons there. One is you get in the mouth, and most people don't want you to get in their mouth after they've eaten. So it's preferable to do it prior to the clinical swallow. You're going to assess the structures at rest and in motion. You're looking for symmetry. So is the right side the same as the left side? What's their range of motion? What's their strength, and what's their coordination? So those are the 4 areas for each of the different structures. So the structures are the face, the lips, the teeth, the tongue, the landmarks in the oral cavity like the facial arches, the velum, the posterior pharyngeal wall. I like to start at the front and work my way back, but again, at rest, in motion, and you're looking at all 4 of these characteristics for a thorough oral motor examination. And it makes sense that we do a thorough oral motor examination because we're looking at the oral phase. I didn't go very deeply into the phases of the swallow, but I'll do that real quick, and then I'll ask this little question here to see if you can. This is a question I ask my graduate students when I lecture for them, and it's kind of fun to watch them sit there and be perplexed. So we'll see if our general public can get it too. So there's actually 4 stages of the swallow, but for this conversation, we'll talk about 3. The oral phase, which is the voluntary phase of the swallow. So in other words, if I give you a piece of gum, you're going to put it in your mouth and you can chew it up. And you can start and stop chewing. You can move that gum around in your mouth wherever you want it to be. You can put it over in your cheek and let it sit for a while. You can put it up on the roof of your mouth, whatever. It's voluntary, meaning that you can control it. You can start it and stop it. The pharyngeal phase of the swallow is that second phase, for the sake of our discussion, where it is automatic. So again, envision yourself, now you're sucking on an ice cube or a lifesaver. And you can suck on it, and you can move it around and play with it in your mouth. That's the voluntary oral phase. And then it hits this magic spot, and it's gone. And you're thinking, whoa, you just swallowed that lifesaver or that ice cube whole, and you didn't choke on it, but it went down. And you didn't plan on it going down. What you experienced was the swallow reflex. And when you hit, it's in the area of the facial arches, which is kind of, if you think of your mouth, if you look in the mirror and you can see your uvula, which is the hanging down thing, and then it kind of, your sides of your mouth back in the back, those are your facial arches, okay? And so in that area, you hit that reflex. And once it hits that, it is no longer voluntary. It is automatic, and it's gone. And you cannot bring it up until it gets all the way to the bottom, nor would you want to, okay? And you didn't choke on it because it all worked properly. It triggered, your esophagus opened up, and down the chute, okay? Completely automatic. And then, of course, the esophageal phase, which is where it goes down the esophagus and into the stomach. And there it has a sphincter on top that opens up and allows that automatic phase to continue and move down in a peristaltic way. So if you think of like a snake, you can see the snake eating a mouse, and you can watch it go down through the snake. Well, we are the same way. It's just that we have vertebrae on the back and our trachea in the front, and so you can't see your esophageal peristalsis as your food goes down your esophagus, but it does exactly the same thing. It moves down in that kind of pinching, squeezing way until it dumps into your stomach. Okay, so that's a healthy, normal swallow. So the question here on this slide is that typically patients with tongue thrust demonstrate oral phase dysphagia, the voluntary part in the mouth. And sometimes they'll demonstrate oral pharyngeal dysphagia, right? I talked about that earlier when I was talking about the research is starting to show that the oral phase can lead to oral pharyngeal in severe cases or as they get older. You can't compensate as much for that reverse swallow as you get older. You know, just like we all walk slower and talk slower, well, you swallow slower too. So that compensatory reverse swallow using the front of the tongue just starts to break down with age. It just does. And we're starting to actually get measurements and enough data on enough people to show those trends. But here's the kicker. A tongue thruster will never demonstrate a pharyngeal dysphagia in isolation, meaning only pharyngeal dysphagia. And why is that? Well, why that is because by definition, it's oral phase dysphagia. The tongue is in the oral phase. The tongue is not, the anterior tongue is not in the pharyngeal phase. And so the pharyngeal phase it has other characteristics. But for the tongue thruster, we're talking about the oral phase dysphagia. That is important, okay? And we'll get into that here. So the clinical swallow evaluation, we're going to address structure and function just like we did in the oral MEC, but now we've added food. So we're going to look at a variety of textures. We're going to look at solids and liquids. We're also going to look at saliva. How do they manage their secretions? I can tell you 99% of my tongue thrusters manage their secretions absolutely splendidly. Not a problem at all. Liquids, depends. Solids, depends. Okay? So the degree of their, and I guess I have kind of a warped perspective because the other side of my career is working with the elderly and swallowing. And so this population we're looking at, they have a hard time with liquids because it moves quickly. They have a hard time managing it. Their tongues are weak, or they may have asymmetry because of a stroke or those kinds of things. You just don't see that in tongue thrust. So relatively, if I'm looking at them with a typical speech path clinical swallow eval goggles on, they're all going to look normal. They're all going to look extremely talented because we're comparing them to disordered swallows of individuals who have either age or neurological impairments that have affected their swallow. So with that said, we're looking at how they're swallowing. So rather than looking at the safety of their swallow, we're looking at the mechanism of the swallow, how they're swallowing. Are they swallowing with that up and back squeeze, or are they swallowing with a bullfrog, pushing forward and flipping back? So you see this bulge under their tongue when they swallow, rather under their chin, I'm sorry, when they swallow, because the base of tongue is moving forward rather than an elevation where it's moving up and back. And again, I'll show you some snippets of that in the course outside of this particular recording. Understanding again that we're looking, you do still look at that pharyngeal phase because there can be times when there is an oral pharyngeal side of it. The other side that I guess I should have mentioned, I was trying to simplify it, but there are 4 phases of the swallow. The first phase is actually the oral prep. So the oral prep is getting the food from the plate or the cup or whatever, the straw, into the oral cavity, into the mouth. And we do look at that with tongue thrusters because you tend to see the tongue coming forward and toward the straw or toward the spoon. It comes out in anticipation of that bolus coming in, and so it catches it early. So we do look for that, and that is very common. Again, we are looking really heavy on the oral phase because that's where the primary dysfunction is at. So the 3 hallmarks of tongue thrust that I alluded to earlier are these. It is that depressed forward resting posture. So at rest, what are you doing right now? And that's the question I often ask. Right in the middle, you know, I do the education after the assessment because I don't want them to know what it is I'm looking for, because if you know what you're looking for, you're going to change your behavior. Okay, so that depressed forward resting posture is hallmark. The forward thrust of the tongue during the swallow, what I was talking about, where they push it forward and flip it back, and that doesn't have to be visible. You don't have to see it coming through the lips, but it will be coming through the teeth, and you will see it in that bullfrog, okay? And then the reverse swallow. And again, the reverse swallow you definitely see with the bullfrog, and that is the active result of 1 and 2. So those 3 go together. And so in my opinion, those are the hallmarks. If they have those 3, now they may have just the depressed forward resting posture and no reverse swallow, well then they're not a tongue thruster. They may not be thrusting their tongue forward during a swallow, then they're not a tongue thruster. So they have to have all 3 of those characteristics in order to have the diagnosis of tongue thrust and oral face dysphagia. That information obviously comes from that comprehensive assessment that the clinician does. All right, time for another break. We will wrap up here with interdisciplinary professional networking and collaboration here in a little bit.